This is the MedicCast, September 20th, 2010.
Transmitters? We don't need no stinking transmitters.
This is the MedicCast, a podcast for EMS providers by EMS providers, featuring EMS news, products, tips, tricks, and commentary. So grab your gear and glove up. Here's today's show with the pod medic, Jamie Davis.
Well, good day and welcome to this week's episode of the MedicCast. I'm your host, Jamie Davis, the pod medic, and I'd like to welcome everybody to the show this week. If you haven't already done so, you definitely want to make sure you head over and check out the MedicCast blog over at mediccast.com/blog. You'll find links to everything in every episode over there in the show notes link right at the top of the page. Just click that link and you can find the most recent episode listed at the top of the page, and then you can scroll down and find previous episodes. Go ahead and follow up on links to news items, links to additional resources when we have a tip of the week. All of that is provided for you there. And of course, we also put up other articles and information throughout the course of each week. A lot of good information over at the MedicCast blog. And I look forward to checking in with you when you leave comments there, or if you sign up for the MedicCast email newsletter. All of that's available over there. Of course, you can always send me an email directly. Shoot me an email with any of your comments, corrections, suggestions for future episodes or links, anything you need to talk to me about. Check in with me. I love to hear from any and all of you. And you can shoot those emails out to podmedic@mac.com. And I will return your email. I return every email. I really work hard at doing that. It might take me a couple of days, but I will get back to you. And maybe I can share your comments or questions here on the show. You can also find me over on Facebook and Twitter under the handle PodMedic. So twitter.com/PodMedic and Facebook.com/PodMedic. And don't forget the MedicCast Facebook fan page. You can find all sorts of additional information, including other questions, comments that I post throughout the course of a week, just for the Facebook fan members. And you can find that at facebook.com/MedicCast. Just click the like button at the top of the page there, and you will become a fan of the show. And then if there's something posted there, it'll show up over at your Facebook page. You can come back and comment back on it, leave your suggestions. I ask questions for future tip ideas over there, and I also post information, links to videos, and other important things that might be cropping up. And you can find that over at the Facebook fan page for the MedicCast. We'll get into our listener email. Let's check in with that here in just a sec. So let's jump in and take a look at a couple of listener email items here. First off is an email from longtime listener and supporter of the show, Dan, checking in from Long Island, New York. And Dan was letting me know that he is finally moving forward from EMT and going to work on his paramedic program. And I think that's, let me look at my email here, St. John's University. So, hey, Dan, congratulations on making that move. And I hope that you will continue to listen to the show. I know you said in your email that you appreciate all the information you get from the show and are looking forward to using that to help you move forward as a paramedic. And that's great. So anything we can do, make sure you keep in touch. Let me know how school's going. And it's great to hear from you. I know it's been a while, but don't feel bad. Just check in when you can. Let me know what's going on. And I hope that we can continue to put out great information here from the MedicCast community and help you out a little bit. So definitely keep in touch and let me know what's going on. And I know a lot of you out there listening and watching this on the video segment are paying attention to the show because of your studies as an EMS provider or student, and that might be as an EMTB student, a paramedic student, an EMTI student, whatever the case may be. You know, if there's something you want to find on the site, use that search box at the top of the page, the MedicCast blog, and I'm sure in the last 250 odd episodes, we have looked at something related to a topic you're looking for, and maybe we can help provide you some additional study material in that way. And of course, don't forget the MedicCast Extra is available as well, with lots of additional resources and information over at mediccastextra.com if you're looking for something that you need to really get an additional leg up for your studies. Dan, thanks for checking in, and I look forward to hearing more from you. Let's check the next item here. And this is from listener Eric. He's an EMTB, just finished his training. I'm not sure where Eric is located, but he's looking to get a job as a firefighter EMT. And jobs are pretty scarce, and he wanted to know what I recommended. Should he continue to try to get a firefighting job, or should he join a local volunteer service and get some experience there riding the ambulance, or work for a private ambulance company? And you know, it's hard, Eric, for me to give advice on something like that, because every area is so very different in how it's operated and how the services work together. And so it's difficult. I think anything you can do to get additional experience, that's great. So volunteer service, I'm a member of a volunteer organization, you know, and most of my area is served by volunteer EMS and fire. So I understand that might be a good option for you. However, if you have an opportunity to get a job and work for a paid service, you know, a lot of people will tell you that working for an interfacility transport, just taking old people to, you know, the hospital and, you know, for tests and then back to the nursing home or whatever, is a waste of time and not a good use of your skills. And I would say that those providers that say that are really not looking carefully at how they can learn from every single patient that they have come into their care. I don't care if you're driving a wheelchair van or what. There are opportunities to learn and figure out what's going on with your patients and develop a better knowledge of how to treat all patients. But even if it's just reading over a medication sheet and understanding what medications are given for what problems, understanding patients' changes over time as medical issues are resolved or crop up, all of that is important, and you see a lot of that, and you have a lot of time to assess that and learn more about it when you do interfacility transports. It's a great opportunity to really get a handle on what's going on with patients beyond that initial emergency care. And so what it does is it makes you a better provider for medical cases, which are much harder to diagnose. I mean, basic trauma care is essentially BLS. And we all are in this for, you know, in some regard, for the action of the motor vehicle accident and the serious situation. But that means we're really good at trauma and not always as good at medical assessment and diagnosis. And so being a good interfacility provider will make you an excellent medical clinician. So I just would put that out there. Eric, I hope you will keep in touch with me and let me know what you ultimately decide and what seems to be the best option for you, because it may help someone else here at the show. And thanks for checking in. I look forward to hearing back from you. Next up, I got an email in from listener Daniel checking in. We did an acetaminophen episode a couple weeks ago, 2-3 weeks ago, and then got an email from a listener in Australia asking about, you know, they don't have acetaminophen there. And I thought it was kind of odd because, good grief, I mean, it's Tylenol. You know, I think it's pretty ubiquitous here in the States. I can't imagine it's not being used in other parts of the world. Well, it turns out that it goes by a different name in other parts of the world. Certainly in Australia, it seems that it's paracetamol. So if you're an Australian provider listening to the show, we have a lot of you checking out the MedicCast. If you haven't heard of acetaminophen or Tylenol, how about paracetamol? So that may be something that you're much more familiar with, and that is apparently, according to Daniel, the same thing. So I hope that clears that up. And speaking of Tylenol, we got a voicemail in from listener Stefan from Quebec, and he's just checking in to let me know a little bit about what's available in his area with regard to Tylenol medications in response to this question about international names for drugs. So let's check out. Let me go ahead and pull that up here, and we'll check out what he has to say.
Hey, Jamie, it's Stefan Beguise from Quebec, or Paramedic 0750. You were talking about Tylenols. We do have them here in Quebec. We have all kinds. We have the regulars. We got 500 milligrams. We got cold and flu symptoms. We got a couple of those. Afterwards, I've listened to the nebulizer, the alcohol thing, and was surprised to find out that it did happen. So I'm going to check it out, you know, in my region. I don't know if we had cases in here. The main drug around here for these days is GHB mixed with beer. We got ourselves some kids, you know, that are way too much banged out, and they do it on purpose. It's not, you know, the accidental GHB thing. They put beer and GHB, and we have to carry them because they're knocked out. So continue with your show. It was real nice to hear that, and hope to see you soon in a convention or something like that. Take care.
Hey, Stefan, thanks a lot for calling in on the voicemail line and leaving that message. Stefan's talking about, the Tylenol in Canada, so he's sharing that information with us. Sounds like it's very similar to what we have here in the United States. And also checking in about something that listener Heath had sent in a voicemail message a few weeks back, talking about the use of a nebulizer. So people were stealing nebulizers out of ambulances and then using that nebulizer to administer alcohol to themselves in a nebulized mist and inhaling it. This is bad, of course, because they inhale the alcohol into their lungs. That alcohol is absorbed directly into the bloodstream without any liver filtration, which you normally would get through your GI tract. And so they can rapidly become toxic via alcohol poisoning. So it's something to be aware of, and Heath was checking in about it, and so that's important to know. And thanks for sharing the information about GHB and beer. The more of you out there that are listening to the show and share via email or calling in through the voicemail line especially, it's a great way for all of us to bring that information together. And I'm going to continue to provide that forum here on the show so that we can tell each other what's going on, so that you run into something, maybe you haven't seen it before, but hey, you listened to the MedicCast and you heard it here, and you were able to share that information with your other fellow providers, and you have a handle up on knowing what's going on before anybody else does. So continue to share that information here on the show, and I'll make sure I continue to share it out with the rest of the listeners. And Stefan, thanks for calling in. If you'd like to call in on the voicemail line, you can do so yourself. Call in to the voicemail line by calling 941-306-3342. That's here in the U.S. and Canada. 941-30-MEDIC is the line here. Or if you're on Skype, you can call to PodMedic is my handle on Skype, and you can just leave a message. It'll go right to the voicemail if you call in on Skype as well. Leave that message, and I will share your comments back here with the listeners on the show. And hey, it would be great to have a show with nothing but voicemails. So let's get a couple of voicemails in for a future episode. Also, he talked about going to convention. Don't forget, we're going to be at EMS Expo in Dallas. So let's see. This show comes out Monday the 20th. So that means the following week, I'll be traveling to Dallas. So Monday the 20th. So if you're going to be in the Dallas area for EMS Expo and would like to catch up with us, come by the EMS Expo Zoll Podcast Studio. We've got our own booth. We're going to be recording at least 10 episodes from our booth live. Stop by, listen to some of the show, hang out when the show's done, meet the other podcasters that are hanging out there, and really, if you see me at the expo, either in the hallway or in the aisles or doing my show, make sure you come by and come up and say hello. And I just want to meet as many of you as possible. So come by, and again, special thanks to Zoll for sponsoring the podcast studio. We also have Philips on board as a sponsor, EMS One as a sponsor, and of course, I want to thank EMS Expo for all of their support in allowing us to come in and provide video coverage of the event. So if you can't make it to EMS Expo this year and you want to know what's going on there, make sure you follow what we're doing here on MedicCast.tv. I'll be posting videos up there. You can also find video coverage over at the EMS Expo site. And I also want to urge you to make sure you're keeping track of what's going on with the guys at chroniclesofems.com. Ted Settler's going to be there. Justin Shore is going to be there. Natalie Quibido and Jeremiah Bush, who are doing part of their project for the Chronicles of EMS. All of them are going to be there, and I urge you to catch up with what they're doing. They'll be providing some video coverage as well. That's it, and I want to thank everybody for checking in on the show this week. Before we go any further, I do want to thank our sponsor, GoToMeeting. GoToMeeting has sponsored this show off and on for several years, and it really is a resource that I really couldn't do without. For those of you out there that don't know what it is, think of a way that you can get together and meet with people without having to leave your house or leave your station. You can bring a group of people together and conduct training, conduct updates, hold a meeting for supervisors or whatever the case may be, you can do it quickly and easily using GoToMeeting. It's easy to set up, takes just a few minutes, probably less time than it takes to listen to this commercial. And the best part is that all you do is send somebody an email link, they click that link, and GoToMeeting opens up on their browser. They can see your computer, they can watch videos that you play for them, PowerPoint presentations, they hear your voice over their computer line, and actually, they don't even need a conference call because you can open up their microphone and they can talk back to you from their computer. It's easy to use, simple to set up, and you can use as many calls, conferences, meetings as you want for one low monthly price. Not only that, you can try it out for free. 30-day free trial just for listening to the show. If you haven't tried it out for free, why aren't you doing that? Head over to gotomeeting.com/podcast. Check it out and try it out for free today. That's right, gotomeeting.com/podcast and try out GoToMeeting for free today. And thanks for sponsoring the MedicCast. Let's jump on into this week's news items, and I'm going to start off with a look at ambulance accident that happened in North Carolina. Now, thankfully, injuries apparently were minor. There was no patient on board during this particular call, but it is important for us to pay attention to these types of stories. In this situation, there were no other vehicles involved. The ambulance apparently somehow ran off the road, ended up on its roof on the on the median strip of the road, and that seems to be, no excuse for that. So what are we talking about here? Well, first off, I'm not going to just go into how the accident happened. There's not very much information on how the accident occurred. So let's talk a little bit about just general driver safety. It is incumbent upon us to be safe drivers whenever we're operating a motor vehicle. That goes without saying. When you're operating a motor vehicle as a medical professional, we have to worry about other people hitting us, but we certainly don't need to be cause of accidents on our own. So if there's a situation where you've got something to do, if you've got to text your girlfriend, then pull over and swap out and let the other guy drive. I mean, it just comes down to that. We can't be doing unsafe things. And I don't know that whatever was occurring in this accident, I'm just making an example, but I know that examples like this have happened in my own area. I know when I was chief, we had all kinds of issues with people talking on cell phones while they were driving the ambulance, coming back from the hospital. It was one thing to answer a call when you've got to pick up the radio and talk on it, or you've got to respond to someone important call from an officer or somebody trying to get in touch with you, or you're calling for directions, whatever the case may be. Do so safely. And again, usually you're driving with someone else in the vehicle with you, so there's really no excuse if someone else the passenger can make the driving call and get directions and let the driver pay attention to driving. So like I said, I can't say what happened in this particular incident in North Carolina. Luckily, it seems like the injuries were relatively minor and everyone's going to be okay. But as the chief here said in his response in the article, we have a public trust to operate our vehicles safely. We're the ones that are supposed to be getting to the hospital, to the scene, and to other places safely. Luckily, no other vehicles were involved in this accident, but I just want to remind each and every one of you that we are not immune to the stupidity that happens and causes other accidents. And so we should be more vigilant than anyone else is to make sure that we're not going to do those things that cause accidents. Just because we see everybody else's accidents happen doesn't mean that we're somehow immune to them. We can make mistakes too. So let's just avoid some of these problems by putting ourselves in situations where those mistakes don't happen. And that means not answering your phone, not texting, not getting distracted while you're driving an emergency vehicle, and operate our vehicles safely out there. Next up in the news is another interesting story about emergency responders. Out of Illinois, Springfield, Illinois Fire Department refused to help paramedics lift a 700-pound woman when they were returning her home from the hospital. The ambulance had brought her from the hospital to her home and they needed assistance. They called the fire department and were told that they could not provide lifting assistance. So let's talk a little bit about this here. It seems to me that first of all, this was listed as the policy since 2009 in the Springfield Fire Department that they will not provide lifting assistance for patient lifts if it's not an emergency call. So a patient coming home from the hospital is not an emergency. That patient's stable. They're returning from the hospital home. That assistance for them needs to be provided by someone else. And that's their policy. What I think the breakdown here is, and let's not talk about whether the firefighters have a job to provide that service to the community regardless. Let's talk here about safe lifting practices. Let's talk about why didn't the ambulance service have the proper equipment? If the fire department's worried about back injuries from lifting patients improperly, well, then we need to make sure that there's proper bariatric equipment to help transport these patients into their homes safely. And if there's not proper equipment to do so, nobody should be lifting that patient. I don't care how much, they got to pay extra. I'm sorry, it's the way it goes. That's, they pay extra for critical care. If they're that heavy, they need to pay extra for bariatric care as well. So that's part of it. But if this is the policy of the fire department, then darn it, they need to make sure that policy, that they make that information available to surrounding agencies, including private ambulance services that might have used their services in the past. Just making the policy out of the blue, we need to communicate with each other better. And if that's the case, this shouldn't be a news item. If this was the policy, it doesn't matter whether they refused or not. If the policy was in place, the policy should be honored. Then the ambulance company should not rely on public safety officers from other departments or services to come in and do that lifting assistance if they know that that's not the case. It should not be a news item. But we should communicate better with each other on what our expectations are and what services can actually be provided in a mutual aid situation, even if it's a non-emergency situation. So that's my take on this story, and it means that you need to know if you operate like I do with several different departments in surrounding areas and different municipalities have different rules, you should make yourself aware that, hey, this town will come and help me do lifting on a non-emergency patient transport call, but this other city, they aren't going to be able to give me any assistance. And if you know that, then you've got to get mutual aid or bring in additional people to help you lift from somewhere else. And if you know about that in advance, you should be able to take care of it. So make sure you educate yourself about the services that are available to you with both emergency and non-emergency situations. Speaking of communication, this last story here is a great story of a training exercise held in Boulder, Colorado. At the Boulder County Fairgrounds this past week, they had a weapons of mass destruction, mass casualty drill with police agencies, EMS agencies, fire agencies, state response agencies, everybody coming into the fairgrounds to respond to a bomb with a suspected nerve gas attack. And of course, they didn't know that when they came out for the drill. They just said there's going to be a drill, and the drill turned into this major event that they wanted to simulate. These are great opportunities to forge and cement those bonds between us and a neighboring agency or mutual aid organization. And this is where that communication starts. I talked about in the last article, is where we talk about how we work well together and how we understand what other agencies can and can't do for us in certain situations. All of that starts with big drills and planning and training exercises like the one that they held at Boulder. It's a great description of what they set up there. Big drills like this are great. You can do this with your own agency, your own company, your own organization with a neighbor, a single mutual aid company, or your local police department, or your sheriff's office, or fire department. Pulling just a couple of crews together and practicing working on, even a multi-patient car accident where you have 4 or 5 patients. It can be overwhelming to the crews that are there initially. And you can practice working together and have an understanding of who can handle what, who's going to take on what job responsibility in that situation. And all of that, by planning up front a little bit, doing a little bit of cross-agency training, even on a smaller scale, can help out greatly when other incidents happen and you have the opportunity to need each other's specialized training and services in a specific situation. So take advantage of those opportunities when they come along, large or small. Don't just think that you have to do this giant mass casualty drill. You can do a lot of different things, and you can train in a lot of different ways. Be creative. I hope you'll check out the links to this and every other news item in the show notes. You'll find those links over at medicast.com/blog. There's a show notes link right at the top of the page. Just click on that and you'll find the most recent episode listed there, and you can scroll down and find other episodes. Once you get on the episode page, you'll find the news links, tip links, and everything else for that show. And I urge you to follow up on these, share them with people you know, and of course, share the MedicCast with other professionals in your service. Time now for this week's tip of the week, and we're going to jump into a quick segment here with Lisa Booz from the Maryland Poison Center. And Lisa's going to be talking to us about antidepressant overdoses. I'll be pulling in Lisa for some additional segments coming up to wrap up the rest of our year with a monthly segment from Lisa. In the meantime, I urge you to check out all of her information and other great things that you can find resources from over at the Maryland Poison Center site. And you don't have to be from Maryland to visit that website. Head to mdpoison.com, sign up for the Tox Tidbits email newsletter, all the other information and links they have provided for you there. It's a great resource. And of course, find your local Poison Center's website and hook up with them and share that information with the people in your region and let them know what's going on. So let's check in with Lisa with her segment on antidepressant overdose.
And we're back again with another segment of Tox Tidbits with Lisa Booz from the Maryland Poison Center. Hi, Lisa. What do we have this month?
Hi, Jamie. Well, this month I thought that I would talk a little bit about antidepressants, since they're widely prescribed in the United States and they seem to be used in a population at high risk for overdoses. In 2007, there were more than 97,000 antidepressant overdoses that were reported to poison centers in the United States. So it's important that EMS providers, nurses, and physicians, all the healthcare providers out there, have a little familiarity about what to expect from these antidepressant overdoses and how to treat them. So let's start with the tricyclic antidepressants. These antidepressants have been on the market for many years, and at one point in time really were the standard of pharmaceutical care for patients with major depression. Some of the more common tricyclic antidepressants that you might be familiar with are amitriptyline, imipramine, dizipramine, and nortriptyline. These antidepressants were a common cause of overdose deaths until the early 1990s, when newer and safer antidepressants started to come out on the market. So although the number of overdoses has declined since then, they're still widely prescribed, and they are responsible for more deaths per prescription than all of the other antidepressants combined. Now, the tricyclic antidepressants have several mechanisms of action that produce their therapeutic and their toxic effects. First, they inhibit the reuptake of serotonin and norepinephrine, and that's really how they improve the symptoms of depression. They also have anticholinergic activity, and that produces atropine-like effects. The cardiovascular toxicity, which is a common cause of morbidity and mortality from these drugs, is due to sodium channel blockade and alpha-adrenergic blockade. And all of these mechanisms kind of put together will give you a vast scenario of different types of signs and symptoms that appear in these patients. After an overdose, symptoms usually develop pretty rapidly, and usually within minutes or definitely within an hour. And they include tachycardia, drowsiness, and confusion. And then those symptoms quickly progress to more severe symptoms like coma, seizures, and hypotension. And actually, it's the refractory hypotension that's one of the most common causes of fatalities with these drugs. A wide variety of cardiac arrhythmias can occur. Most commonly, sinus tachycardia is seen, but you can also see conduction delays, and that usually shows up as a prolongation in the QRS interval, so we do recommend monitoring for that. Now, seizures can occur, and seizure-induced acidosis can also make the cardiovascular toxicity worse. The initial treatment of an acute overdose consists of activated charcoal orally or by NG tube to prevent the absorption of the drug. It's most effective if you can give it within the first few hours of the overdose, and certainly in a patient that's awake and alert and can protect their airway. Sodium bicarbonate is first-line therapy for tricyclic-induced dysrhythmias. Sodium bicarb actually alkalinizes the serum, and this alkalinization improves cardiac conduction, it increases the blood pressure, and it will reverse metabolic acidosis. The dose that's usually recommended is somewhere in the order of 1 to 2 milliequivalents per kilogram. That's given as an IV bolus, and then that's followed by repeat boluses, or often once the patient gets to the emergency department, they're put on an IV infusion of sodium bicarbonate. Measurement of the patient's serum pH guides the dosing of the sodium bicarbonate after the initial dose or two. Sodium bicarbonate should be given in conjunction with supportive care measures. Vasopressors such as norepinephrine, IV fluids, and anticonvulsants should be given as needed. Lithium is another drug that's been used for years and years. It's generally used for bipolar disorder and depression. It can be quite toxic when taken chronically or in acute overdoses. Either way, people take them chronically and their levels go high, or they take an acute overdose. With just a change in their fluid or salt intake, or they may be dehydrated, they might have a change in their kidney function, they might have added new medicines, or they may just have an onset of an acute viral illness. Chronic toxicity can develop in any one of those circumstances. Patients with toxic levels of lithium will develop vomiting, tremors, drowsiness, seizures, bradycardia, cardiac arrhythmias, hypotension, and coma. Patients acutely toxic, so they've taken an overdose all at once, they usually have more in the way of gastrointestinal symptoms, more so than the chronic overdoses, but those chronically toxic usually exhibit more severe neurological effects. Treatments primarily supportive care and hydration to increase the excretion of the drug. Activated charcoal does not bind to lithium, so it really should only be given if you suspect that the patient has taken other drugs as well. Gastric lavage is appropriate to use. We don't generally recommend gastric lavage in this day and age, but it is okay to use that for lithium overdoses since activated charcoal is not effective, but only if the ingestion has been within an hour of the presentation. Another method of preventing absorption that's sometimes employed in acute lithium overdoses is something called whole bowel irrigation. Now, this involves administering large volumes orally of a polyethylene glycol electrolyte solution such as Go Lightly. Whole bowel irrigation essentially just flushes out the tablets through the GI tract before they have a chance to dissolve and be absorbed. Another method of removing lithium once it is absorbed is to use hemodialysis, and that's considered for patients who have developed severe toxicity or patients who have renal failure. Now, there's a fairly new antidepressant out now that's commonly prescribed. It's really unlike all of the others, and it's also associated with severe toxicity, and that's called Buproprion. It's more commonly known by the brand name Wellbutrin. Tachycardia, tremors, and seizures are the most common toxic effects and can be seen with relatively small doses, even in some cases just double doses. Seizures occur within 1 to 4 hours if the product is an immediate release preparation, but the seizures can be delayed if the product is sustained release, such as a product like Wellbutrin SR or Wellbutrin XL. We've seen a number of patients reported to our center who remained asymptomatic or had very mild symptoms until right around 12 to 24 hours later when the seizure suddenly occurred. As far as treatment, activated charcoal should be given to patients who are awake and not seizing to prevent further drug absorption, and benzodiazepines like Valium or lorazepam or even Versed are the choice drugs for seizures. It's fortunate now, however, that we do have newer antidepressants that have been discovered and marketed that really aren't as toxic as the tricyclic antidepressants or lithium or bupropion. The selective serotonin reuptake inhibitors, we commonly refer to those as the SSRIs, they've become widely prescribed for depression, and many thousands of overdoses are reported to poison centers each year. In fact, almost half of the antidepressant overdoses reported to poison centers in 2007 involved the SSRIs. A few common SSRIs that you might be familiar with are Prozac, Zoloft, and Paxil, but there are a number of other SSRIs that are out there being prescribed. Fortunately, in overdoses, most patients only develop mild symptoms such as tachycardia and drowsiness, and there are some rare cases of cardiac dysrhythmias. Two other drugs, venlafaxine, which is known as Effexor, and desvenlafaxine, which is now sold as Pristiq, are very similar to the SSRIs in their mechanism of action and their toxicity. So regardless of which antidepressant is involved in an overdose, it's really important to call the local poison center at 1-800-222-1222. And the specialists at the poison center will be able to help you to anticipate what symptoms that might occur in that patient and how best to treat that patient.
Well, Lisa, that's a whole lot of information, and I appreciate that. That's going to be very valuable to the listeners of the shows here, and we'll look forward to hearing from you again next month.
All right, Jamie, I'll talk to you then.
And I want to thank Lisa again. We couldn't do it without her. I'll tell you, I am so happy that we've developed this relationship with Lisa and the rest of the folks at the Maryland Poison Center to provide these regular updates for you. And I hope that you're enjoying them as well. Send me an email and let me know what you think of Lisa's segments. If you like them, if you don't like them, let me know. She is just fantastic and has been very helpful to us. And I would love to send her a comment and touch base with her and forward something on to her from one of you to let her know what you all think and how much you appreciate her taking her special and precious time to get together with me by phone every couple of months and record a bunch of these segments in a batch and putting that information together for us. So I hope that you would let me know how that is. But Lisa, thanks a lot. Again, mdpoison.com for the Maryland Poison Center. You don't have to be from Maryland, but you can head over there and check out the resources, the links, and of course, sign up for their Tox Tidbits email newsletter. It's great. They send out a one-page little update by PDF. So they send you a link. You go and click on that link. It'll download the PDF to your computer, and you can open that up, print it out. It's a one-pager. It's great for putting on a station bulletin board, just quick and easy information about a topic each month. And Lisa is just has a great opportunity to provide that to you, and I hope you'll take advantage of it. And again, Lisa, thanks a lot, and we'll look forward to more segments coming up soon. And that's going to wrap up this week's episode of the MedicCast. I want to thank everybody for checking out the show this week. If you haven't already done so, make sure you head over and check out all of the links in the show notes. MedicCast.com/blog for those show notes links. You'll find the link for the show notes at the top of the page. Make sure you follow up on this information. I can provide basic information. Lisa can come in as she did this week and share a tip of the week, but we will always provide additional information and links for you to follow up on. And that's what your job is. So I can give you broad overviews. It's your job to follow up on that information, check out your own protocols, instructional guidelines, and information, and understand how you apply this information within your own specific scope of practice. If you want to get back in touch with me, I'd love to hear from you. Shoot me an email to podmedic@mac.com. You can also call in on the voicemail line. Remember, that voicemail line is 941-306-3342, 941-30-MEDIC. So call in on the voicemail line and share your questions as listener Stefan did in this episode. Reach me on Facebook, facebook.com/podmedic and twitter.com/podmedic if you want to catch up with me there. And don't forget the MedicCast Facebook fan page at facebook.com/MedicCast. Just click the like button at the top of the page to become a fan of the MedicCast on Facebook. We're almost to 2,000 fans over there. Can we get to 2,000 before EMS Expo coming up? Let's see. So if you're not a fan already, or you know somebody who isn't already a fan over on Facebook, send them that link or head over there and check it out yourself. Click the like button at the top of the page and become a fan of the MedicCast. That's it. We're going to close out the show with some great pod-safe music, and we will do so with Matthew Ebel. We haven't played anything of Matthew's in a while, so let's check in with Matthew's song, Downtown. If you like what you hear, you can find more links to his music over on the site, including a link to check out his songs over in iTunes. And if you like what you see, pick up one of his songs for $1.29, whatever the case may be. It's not very expensive, and it's a great way to show your support to these great independent music artists as they share their music with you via the shows like mine. So check out Matthew's stuff over there, and you'll also find a link to Matthew's website on the show notes for this episode. That's it. I'm Jamie Davis, the Pod Medic. I'll be back again next week. When you get next week's episode, I'll actually be getting ready to travel to EMS Expo. So I hope that we run into you there if you're able to get to EMS Expo, or that you'll check back here at the MedicCast site and you can go directly to those video updates at mediccast.tv. In the meantime, I want to remind all of you to please, folks, remember scene safety and BSI.
country girls still wanna roam, 'cause the bright lights of the city at night will rain down like a curse on a small town. The music swinging and bringing the pretty girls, so the fellas will get up and get out and get on the train going downtown. Take me downtown. Well, Sally couldn't see a future past the end of her nose. She set out for the stars with some pumps and a bag full of clothes. She set her sights on the lights and the action of the shows. But Sally never made it to the road. Now he dropped the legs, but he's looking for sex. A cheap whiskey in a bag full of happiness. He'll suck you in with a sinister grin, a stick pin and a spin that you're gonna win if you go downtown. Yeah, take me downtown. Look a mess, but baby, you better sell or your daddy gonna raise hell. He gives you money, but honey, your daddy don't give a damn unless you got a